I know, it's obviously impossible to cover all of orbital tumors in 1 hour. I also recognize that not all of you are going to be treating and managing orbital tumors in your practice, but hopefully we can give you sort of a broad overview so that when a patient like this shows up in your office, so you have at least some framework to sort of, how to approach this, how to maybe do some initial workup and diagnostic testing, and how to make the appropriate referrals that are necessary. So over the course of the next hour or so, we're going to go through kind of an outline of just, basically a few basic tumor types. We'll start out with some introduction of terms, a few thoughts on imaging and initial diagnostic studies, and then I've kind of organized things a little bit just basically by basic cell types. So in general, there's obviously a lot of types of tumors that can present in the eye socket and also a lot of mimicking lesions. Again, we can't certainly cover an entire breakdown of every single type of orbital tumor the next time. So I'm going to focus this talk mostly on true orbital tumors, not as much on some of the mimicking lesions. This was a giant review from the Wills Eye Hospital in Philadelphia with the Shields group of all of the tumors. They had basically seen about 1,200 orbital tumors, and I know this is a very small font, so it's impossible to read that, but basically it kind of broke down to the most common being, I'll go back here. Vascular tumors being, kind of by far the most common. Secondary tumors, meaning things that are either metastatic or invading from the adjacent sinuses, the conjunctiva, the eye. Inflammatory lesions, which we won't spend as much time talking about today. Lymphoma and leukemia are probably the most common primary orbital malignancy that we'll see. Lacrimal gland tumors and kind of down from there. So, a few basic terms. Orbital tumors can kind of break down into two types, either hamartomas or chorostomas. Hamartomas are sort of abnormal proliferations of cells that are normally found in that location. So there's cells that are already there that are sort of behaving in an abnormal way. Chorostomas are cells that come from other areas that don't normally belong in the orbit. So as we go through the different tumor types, you'll see sort of how those tumors break down into the different types. And then again, kind of a general characterization of how to approach these types of tumors. As we're going through these different tumor types, sort of think about how we're approaching them. Sort of classic things that may show up in the history or in the examination. Thinking about sort of initial diagnostic studies. For most of these, we're going to start with imaging. The next step is usually a diagnostic biopsy and then some type of treatment. So, kind of think about how we're approaching those there. And then, there's certain surgical considerations that are important to think about for each of these different tumor types. And then also, thinking about how we're kind of approaching these globally in terms of treatment. So kind of prior to anything, when that patient shows up in your clinic, there's actually a lot you can get from the exam even before you do any imaging. And I think it's important to sort of have that pre-test probability in your mind before you go to order any studies. So when we think about someone, presenting with a patient who sort of shows up in your clinic like this, just the position of the eye can give you a lot of information on where the tumor may be coming from. So for tumors that are sort of pushing the eye forward, those are most often going to be within the muscle cone, just sort of presenting with axial proptosis or tumors pushing the eyes straight forward. Inframedial displacement of the eye is typically something that's going to be coming from the supralateral quadrant, like the lacrimal gland pushing the eye down and in. Frontal ethmoidal tumors in this region are going to push the eye down and out. Tumors that are originating in the maxillary sinus and coming up may push the eye directly up. So just kind of looking at the eye and which direction it's being pushed, you have some sense of where these tumors may be starting. And then medially, kind of in this region, the relationship with the mediocanthal tendon is very helpful. So things that are originating below the mediocanthal tendon tend to come from the lacrimal sac. Things above the mediocanthal tendon may be slightly more worrisome for cancer, encephalocele, like herniated brain, and things like that. So below the mediocanthal tendon is often reassuring, or at least localizing to the lacrimal sac. And then enophthalmos, I think, is a very useful differential diagnosis for everyone to have in their mind. So a patient without a history of trauma who's presenting with spontaneous inward sinking of the eye socket, the first thing you always want to think about to rule out is breast cancer. But these can also be associated with varices, which we'll talk about, which are distensible venous malformations. They stretch the tissues, and over time that actually leads to enophthalmos. The other important thing for glaucoma patients to think about prostaglandin analog drops causing fat atrophy and sinking in of the eye, or silent sinus syndrome, where the maxillary sinus collapses and pulls the eye in. So I think that differential just in your mind for spontaneous enophthalmos may be helpful in approaching patients who could potentially have an orbital tumor. So just a few thoughts before we again get into some of the tumor types on imaging. I think MRI, if available in your institutions, is typically the best soft tissue resolution for giving details about orbital tumors whenever it's safe and possible to do so. Adding contrast enhancement to the MRI is going to give you the most information about a soft tissue tumor. That said, even in our institutions in New York, it's often easiest and fastest to get a CT scan or a computed tomography scan, especially in any case of where there's concern for trauma, retained foreign bodies. CT is excellent as a first-line treatment, but for additional characterization, whenever possible, magnetic resonance imaging or MRI is the sort of the modality of choice for most orbital tumors. And then just a brief note on angiography. I like how Andy Lee, who's a neuro-ophthalmologist in Texas, puts it. If you're looking for something that starts with an A, an arteriovenous malformation, an arteriovenous shunt, anything with an A in it, you need to order a test with an A in it, like a CTA or an MRA. And similarly for a venography, if you're looking for something with a V, a venolymphatic malformation, a distensible venous malformation, if it has a V in it, some superior ophthalmic vein thrombosis, cavernous sinus thrombosis, those are the things you need to get venography for, and that's an important study to add. My biggest tip maybe for all of this is have a good relationship with your radiologist. I think my neuroradiologist who I work with is probably the most important person in my practice. If I see a patient in clinic and I have questions about what the pathology might be, having a conversation with them is really, really helpful in determining what type of imaging you may want to order. They can give you some tips for sequences, for how to kind of plan things ahead of time, positioning, other things that may be helpful. And then obviously going over the imaging with them afterwards is crucial in sort of making a plan for patients. Just a few examples of imaging. This is just kind of comparing an MR imaging versus a CT imaging with soft tissue windowing. You can just see how much additional detail of this rhabdomyosarcoma you get with magnetic resonance imaging. And then again, whenever you're ordering an MRI, another thing that's important to communicate to the radiologist is that you're looking for dedicated orbital sequences. The orbit is a unique tissue space in that it's sort of filled with fat, which can make imaging challenging. And so whenever you get an MRI orbits, they're typically going to include fat suppressed sequences, and you can kind of see the difference here between this bright fat during the T1 sequence and the fat suppressed sequences, which sort of eliminates the fat and allows you to see everything else that's in that orbital sequence. So fat suppressed imaging is crucially important. If you just get an MRI brain, it often will not include that fat suppressed sequencing. And it may make it difficult to differentiate between sort of subtle orbital lesions. So I think that's another huge tip that's important to communicate to your radiologist when you're either ordering the study or as you're planning. And then CT windowing is an important thing that I always go over with our residents. You really want to have the windowing for the lesion that you're looking at. So if you're interested in a bony process, perhaps sphenoid wing meningioma, fibrous dysplasia, or trauma, you really want to be looking at bone windowing. And you can sort of appreciate here, this is bone windowing on the left and soft tissue windowing on the right, just the additional amount of detail you have in the marrow space and some of these really thin bones. You just get such enhanced resolution. Whereas here in this coronal image showing soft tissue windowing, you certainly have better imaging of the muscles, the optic nerve, the superior ophthalmic vein, but all of the bones sort of is just this bright white where you're really not going to be able to pick up on subtle findings within the bone. So it's important, of course, to look at the appropriate windowing as you're looking at these imaging. So then kind of stepping away from imaging when we think about the locations that these tumors can be in, and this is really more important for people who are actually going to be treating these surgically, but in your sort of conception as you're approaching orbital tumors, these are essentially the 5 spaces within the orbit. And probably the most important for our orbital tumors are going to be our extraconal and our intraconal space. So whether it's within that muscle cone or outside the muscle cone, but certainly things like abscesses and other things that can mimic orbital lesions may present in that subperiosteal space. The subtenon space is really effectively right on the globe before the optic nerve, and the subarachnoid space is essentially within the optic nerve. So when we think about tumor approaches, again, I know not a lot of you are probably going to be managing these tumors primarily yourself, but hopefully some of you will. I heard a few people who are interested in oculoplastics in the group. I'll try to throw in a little bit during the course of some of these tumor types and just how we might approach these and what minimally invasive approaches we might use. Probably the biggest two are going to be our eyelid crease, this one shown in B up here, to get to the deep lateral orbit. The retrocaruncular approach, which I'll show here in a second, where we're essentially going along the conjunctiva, along the medial aspect of the orbit, and then some form of a transconjunctival inferior approach to the orbital floor, where we're going along the inside of the eyelid, perhaps with or without a canthotomy and cantholysis to open up the orbit. And really determining which approach that we take is based almost essentially on the position of the tumor relative to the optic nerve. So when we think about our tumor location, these are both left orbits. So this is our axial view looking up from the feet towards the top of the head, and this is of course a coronal sort of en face image. And wherever that nerve is, that dictates wherever the tumor is relative to the nerve dictates our approach. So for tumors that are medial to the nerve, in either view, we're thinking about potentially taking that retrocaruncular approach because we never want to retract the nerve. We never want to work across the nerve. Obviously, the nerve is the most sensitive structure within the orbit, and we never want to manipulate that or violate that any more than necessary. When we think about tumors in the lateral orbit, we're thinking potentially about that eyelid crease approach to come across the outside of the orbit, not crossing that optic nerve. And then things sort of in the inferior or lateral quadrant, we're thinking about going on the inside of the eyelid, perhaps through that transconjunctival approach with or without a canthotomy and cantholysis to open up the lower eyelid. So again, as we're sort of approaching these tumors, we'll think about these different surgical approaches. Perhaps the highest yield differential, we gave the differential for spontaneous enophthalmos, those 4 things we mentioned. This is another one that I learned as a resident that made me look a lot smarter than I probably was at the time. If someone shows you an intraconal tumor, within that muscle cone that's well circumscribed, that you can really draw a line around, very confined, and you can just see exactly where it is. This is really your top 3 differential, and that's going to give you the correct answer of 90-something% of the time. Maybe not enough for clinical patient care, but certainly for your residents on your rotations. I remember on my oculoplastics fellowships interview, someone showed me a tumor like this, and I said my differential, and it made me look a lot smarter than I probably was at the time. So kind of a big overview. Again, we can keep this kind of informal. If anybody has any questions now, happy to take anything, or we can kind of move through some of the tumor types. If there's something that doesn't make sense or you want me to just pause and answer some questions, feel free to raise your hand or reach out. I'm happy to answer anything for you as we go. So we'll kind of dive into the vascular tumors. We saw in that big Shields overview, vascular tumors, not necessarily true tumors, but vascular lesions within the orbit were the single most common type in the series. So I want to spend a little bit of time dedicated to talking about those. When you think about vascular tumors, they're really categorized by sort of tissue type. So whether it's a venous, a lymphatic, or an arterial malformation, and also flow, whether it's low flow, no flow, or high flow. And all of these, sort of lesions that occur within the orbit can be broken down into one of those types. So perhaps the most common in young children is this capillary hemangioma. So this is a tissue that's a very high flow lesion, and it's made up of capillaries, so it does have vascular connection. The systemic associations that you can kind of think about with these conditions that may be important for, I heard some of you guys doing pediatrics, are this Kasabach-Merritt syndrome, where essentially platelets get sequestered and trapped within these tumors and can cause systemic thrombocytopenia. And also the Facies syndrome with the posterior fossa malformations, hemangiomas, coarctation of the aorta, and the other systemic malformations. These historically were treated with steroids, but now in this day and age are primarily managed with beta blockers, whether systemic or topical beta blockers. And these can occur either on the eyelid or in the orbit. When they do occur in the orbit, they're classically in the supromedial location. And again, this is not really a disease that anyone wants to be managing surgically. They're capillary, they're full of high flow blood. So these are not lesions that you want to be biopsying. They're not lesions that you want to try to typically be excising. These are generally going to be treated with systemic medical therapy. And this is just kind of showing those really small, fine capillary caliber vessels, which will clinically demonstrate high flow through them. Yeah. Cutaneously, sometimes they're treated by dermatologists with laser. I think the beta blockers are so effective that they tend to be the first line treatment, and then laser could be considered down the line, but certainly within the orbit, we would not treat with laser. Yeah, it depends on sort of the response to treatment, but typically given intravenously for sort of systemically. I don't typically manage these myself, so I'll refer them for management. Yeah. And then in contrast to the capillary hemangiomas are these cavernous hemangiomas. Cavernous hemangioma is a bit of a misnomer. The true technical term is a cavernous venous malformation, because they're not really true tumors. They're just sort of this dilated network of these venous channels that sort of form this pseudocapsule and look a lot like a tumor. But they're sort of in contrast to the capillary hemangiomas. These tend to be very slow, low flow tumors that are made up of venous channels. They sort of demonstrate this progressive enhancement with contrast. So this is kind of frame 1, frame 2, frame 3, and frame 4, and you can see it sort of slowly filling with that contrast material over time. And in contrast to the capillary hemangiomas, these ones are surgically excised whenever they're producing a problem. So just because you see one of these incidentally within an orbit does not mean you have to remove it. These are typically tumors that are only removed when they're causing problems. So if they're pushing on the nerve, producing an optic neuropathy, if they're displacing the eye, causing double vision, if they're pushing the eye so far forward the patient's developing exposure keratopathy, those are the times that you may intervene and try to remove these. And then the approach, as we sort of went through, is determined based on the position to the optic nerve. So you never want to reach across the optic nerve. You're always taking an approach that's going to get you directly there and allow you to leave the optic nerve alone. So this was a patient in my practice who presented, was referred by a colleague for blepharoplasty, and he does indeed have some dermatochalasis, but in what we call the worm's eye view, where you're sort of looking up from below at a patient, this is another test, kind of before you consider getting any imaging, you can sort of see that axial displacement and demonstrating some even exophthalmos of that left eye. On imaging, we actually ended up getting CT and MRI. You can sort of see that patchy progressive enhancement within the lesion on MRI, and some bone kind of modeling here, but really a well circumscribed. You can take your finger and draw a line around it very clearly. It was 1/6 size, consistent with a cavernous hemangioma. We took, because of that location in the infratemporal quadrant, took what's called a swinging eyelid approach. So we went transconjunctivally through the retractors. We stayed in front of the orbital septum, followed down to the orbital rim, and then entered subperioscally into the orbit. And I'm not sure how well this image is projecting, but this is our lesion right here. You can kind of see it has that sort of purplish hue to it, just all these little network of vascular channels. The yellow arrow is pointing to the orbital rim. The blue is just sort of showing the lateral canthus and the eyelid being reflected over, and then this retractor is in sort of the lid kind of holding the globe back. This is the lesion once it was excised, and again on pathology you can see compared to the capillary hemangioma sort of these large caliber vessels, and when you look side by side you can kind of see the difference between this capillary hemangioma with these fine capillary networks and the cavernous hemangiomas with much larger. And then the biggest picture to take home, I think, for these two lesions is that the capillaries are managed again medically, and the cavernous hemangiomas or capillary venous malformations, cavernous venous malformations are managed surgically. That was just our patient after surgery. And then kind of one rare presentation that you can see with these cavernous hemangiomas or cavernous venous malformations are actually occurring within bone. So this is an intraosseous presentation of a cavernous venous malformation on CT. You can see this sort of honeycomb or starburst pattern. On the MRI, you see that same sort of pattern of progressive patchy contrast enhancement, but sort of actually captured within the bone. And this was just an example of that lesion being removed. You can sort of see this kind of stellate sort of honeycomb pattern of vascular presentation, but within the bone itself. So sort of one variation of a very common orbital lesion, probably the most common type of orbital lesion we'll see in our practice. So still within that vascular family, these are low flow distensible venous malformations or orbital varices. As I mentioned in the beginning, these actually can present with enophthalmos. These are distensible or stretchable venous lesions that sort of push the tissue out of the way. They'll cause soft tissue atrophy over time, whereas when they're in their dilated cycle, the patient may have exophthalmos with valsalva, so maybe straining to pick things up when using the bathroom, other things that kind of cause them to strain against resistance, and then over time they can actually develop progressive enophthalmos. On the imaging, you can see this fluid level just showing that there's kind of fluid differentiation within the lesion. You have to be very careful with these. This is a lesion you don't want to biopsy. It's essentially very thin wall, dilated venous channels that you don't want to go in and take a piece of tissue. You're going to cause a massive bleed and a difficult problem to clean up. These can be excised when they're causing functional problems, so similar to the cavernous venous malformations. Only if they're pushing on the eye, causing symptomatic discomfort or pain is when we consider removing them. And this is something you want to do work very closely with neurointerventional radiology if you are thinking about excising these. We can actually inject something that's basically like super glue into the lesion as long as it doesn't have connection with the systemic vasculature. So you need to map this out very carefully with your interventional radiology colleagues. Then you can inject the glue, which you can see here. We're sort of following and mapping, and you're seeing the glue in contrast actually fill into this lesion. Once that glue solidifies, it becomes a solid mass that you can effectively remove. But I think from your guys' perspective at this stage, these are definitely lesions you guys don't want to biopsy when you see them presenting clinically, and have a high index of suspicion. For someone who has sort of a lesion that changes with position, you can actually test this in clinic by either having them sort of bend over, put their head between their legs, or bear down and create a valsalva in clinic and do dynamic exophthalmometry. And again, to the point of communicating with your radiology colleagues, if you have a lesion like this, talk with your radiologist. They may be able to get the imaging with the patient in a face-down position that will allow you to capture an otherwise invisible lesion. These varices can thrombose or coagulate and clot off and essentially present with a very rapid, sudden change. So this was a patient who was referred to me for a surgical excision of this mass, and they were actually already signed up for surgery. They had a date and they were ready to go in and cut this thing out. I sort of reviewed the scan with them and our neuroradiologists, and we elected just to observe this patient without any treatment. 1 month later, the lesion had essentially disappeared as this clot had kind of resolved and normal flow had been restored within the orbit. So another reason to really review these scans very carefully with neuroradiology. And this patient did have a history that was more consistent with a varix and a really sudden onset spontaneous change. Lymphangiomas you'll see commonly in children. These may present with upper respiratory infections. They really have no flow within them, but they're based largely on this lymphatic network of tissues that when a patient has a URI or some sort of reactive inflammatory immune process, these things may grow and expand in size. They can kind of bleed within them, forming these chocolate cysts. And on MRI, we'll demonstrate sort of a similar fluid layering pattern. And similar to most of our vascular lesions, if we can avoid surgery on these, if possible, we always want to do so unless they're producing a functional deficit. And an important association to note for these is that many patients will have an associated intracranial vascular malformation as well. So that was sort of a broad overview of the vascular tumors. Any questions on those before we sort of move on to some of our neural-based tumors? So in general, try to avoid surgery on vascular tumors whenever possible. Work closely with your neurointerventional and your radiology colleagues to kind of appropriately diagnose these before considering anything surgically. So our neural tumors can kind of divide it into a few different types. They're obviously based on nerve tissue cells. Gliomas are going to present commonly in a number of ways. Neurofibromas, meningiomas, and schwannomas are our 4 basic types. So the optic nerve gliomas are sort of divided into 2 basic flavors. In young children, these tend to be sort of slowly progressive benign lesions that are really pilocytic astrocytomas. They may have sort of, just gradual, slow axial proptosis and variable symptoms. Some patients will have no symptoms. Some patients will have double vision, strabismus. They may have loss of vision. And treatment is sort of controversial, but really depends on how this lesion is behaving and what problem it is causing. This is really a tumor that's actually made up of the nerve cells itself. So we'll see in contrast in a moment to our optic nerve sheath meningiomas. This is actually made of the nerve tissues, those astrocytes. The other flavor, not just in kids, but these can present more in adults as more malignant, aggressive tumors that are really truly glioblastomas. Those tend to present commonly in adult males and may again present in a much more rapid, progressive, insidious fashion. On imaging, you'll sort of see this fusiform enlargement of the optic nerve. You worry about these lesions sort of extending into the chiasm, and treatment we'll talk about in a second really depends on how rapidly that's progressing. This is a young patient who kind of presented with one of these lesions that was encroaching on the optic chiasm. That was the one I just showed. You can see kind of presenting with axial proptosis. This is a much more severe version of that, presenting with strabismus, proptosis, exposure keratopathy. And these are ones that, of course, will need to be treated. Again, treatment's a little bit controversial, but depends on the tissue type. But in a young child with good vision who has no functional compromise from this, you don't want to biopsy the lesion because it's his optic nerve and you're going to cause vision loss, you're going to cause vascular problems. So these are ones you're just going to observe progressively over time with serial imaging. In patients who are demonstrating rapid growth, the goal is to prevent this chiasmal invasion where it's actually becoming a brain tumor that may be challenging to treat. So those ones that are either growing rapidly, producing functional deficits, certainly in patients who have no vision, and the goal is then, you kind of lost the battle with the eye, and the goal is to prevent them from developing a brain tumor. Those are the ones that you'll excise. And then once they're sort of within the brain, these are going to be treated with chemotherapy and radiation. And this is an example of one that we excised in a patient who had no light perception vision, that we were, the goal was to prevent chiasmal invasion down the line. Neurofibromas, another common type of orbital lesion. These are presenting most commonly in neurofibromatosis and classically in the upper eyelid with this sort of S-shaped deformity. You can sort of see that sinusoidal shape of the eyelid. If you see a patient in your clinic with these classic characteristics of neurofibromatosis, this is a disease that touches many of our subspecialties within ophthalmology. These lesions can be debulked. The goal is not to completely excise them. They can bleed. You don't want to get yourself into trouble, but if someone has a disfiguring ptosis from a mass effect of a lesion in the upper eyelid, these can be safely debulked. It may require multiple surgeries over many years. Again, your goal is not to necessarily get everything out, but to debulk whatever you safely can to give them a functional improvement. Meningiomas basically come in 2 flavors. These are more common in women. They tend to be hormonally responsive. They tend to grow during pregnancy. And the 2 basic types are either optic nerve sheath meningiomas within the orbit or the sphenoid meningiomas that tend to present in the sphenoid wing, maybe with intracranial involvement. And I'll sort of show you a couple imaging examples of those. They arise from the arachnoid villi. And they can kind of be graded based on their degree of dysplasia, grade 1s being the most benign appearing and grade 3 being the most malignant or aggressive. And we'll talk about treatment in a second, but in general, for these sphenoid meningiomas, they can be safely observed if they're not causing functional deficits. If they start to cause problems, that's when you'll start to consider doing some debulking and potentially radiation for higher grade lesions. And optic nerve lesions are similar to optic gliomas. If they're not causing any functional problems, we tend to monitor them serially. Once they start causing vision problems, that's when you start thinking about doing something to debulk them and potentially radiate them as well. So this is kind of a classic example of a sphenoid meningioma with this dural tail. So it's sort of a very characteristic appearance in the temporal lobe. This helps differentiate these sphenoid lesions sometimes from fibrous dysplasia, which can also present with expansion of the sphenoid wing. So this, MR doesn't tend to show bone as well, but this is the sphenoid wing here, this little triangle. You can see, much smaller on the other side from the hyperostosis, but this dural tail is kind of the classic sign you're looking for in a sphenoid wing meningioma. This is an optic nerve sheath meningioma that's sort of similar in appearance in some ways to the optic nerve glioma we saw. This is an older female patient, and you can sort of see almost the optic nerve actually traveling within this lesion. So, compared to the optic glioma that's arising from the nerve itself, this is arriving from the sheath, the meningeal lining of the optic nerve, and so you're usually able to see this sort of pattern of the nerve passing within the tumor itself. But similarly, these can invade the chiasm. With meningiomas, you're never really going to be able to totally resect these. Recurrence rates are very high. So again, you're managing it based on the patient, how they're presenting, what their visual symptoms are. And these tend to be managed often with radiation in areas that are not resectable. They tend to be radiosensitive. And then this is a little bit different, but more extreme example of that sort of sphenoorbital meningioma. This is really a predominantly hyperostotic lesion. So you can see this is a patient who's going to present with axial proptosis. And these can just essentially be managed conservatively until they produce problems like optic nerve compression. You can see the optic canal here on this side relative to the optic canal on this side, and you're starting to see hyperostotic involvement of the canal and the clinoid process that can compress or squeeze the optic nerve and produce vision loss. So once they start to present with that vision loss, that's when you're going to start to work with your neurosurgery colleagues to debulk these, decompress the optic canal to create space for that nerve to breathe and allow the patient to have good visual function. So really, again, observation until visual compromise is sort of the management pattern with sphenoorbital meningiomas. Another tumor type, schwannomas, these tend to be proliferation of the Schwann cells. The Schwann cells, these are, again, in our differential, those really well-circumscribed intraconal tumors. They can malignantly transform, but that's rare. And these are treated generally whenever possible and with surgical resection. This was an example of a pretty extreme one that was involving the orbit and the intracranial space. Was treated with a combination approach through an eyelid crease incision and also a craniotomy to essentially remove the intracranial portion. We did a lateral orbitotomy approach where we actually took the bone off and put it back on to try to debulk it as much as possible. You can see this patient had sort of been unfortunately managed with observation by an outside specialist to the point that she went blind, had essentially a frozen globe, this kind of cranial nerve 3 palsy appearance with a down and out globe. So this was really palliative surgery to prevent further extension or involvement of the carotid artery and things like that. So those are our 4 basic tumor types for the neural tumors. Before moving on to the mesenchymal tumors, any questions at all? Hopefully some relevance here to you guys' clinical practice. I know it's a bit of a laundry list of tumors, but hopefully we're getting a couple of pearls here to allow you guys to approach these tumors. And thinking about, yeah?
You said that for some tumors, just watch them and observe how long?
So it depends on the size. The question was basically how often to repeat imaging. It depends on the size, the location, the presumed tumor type, and also the stability over time. So, if it's in a very precarious location, like at the orbital apex, or there's diagnostic uncertainty and you're worried about something that could be malignant, we could often repeat imaging as early as 3 months. If it's a lesion that tends, sort of demonstrates stability, then you can progressively, expand the interval between your imaging, so go to 6 months to a year. Certainly some cavernous hemangiomas we're not necessarily following yearly once they've kind of demonstrated stability over a long period of time, and we tend to follow them more with clinical metrics. And often things you're going to see clinically are going to be more sensitive for growth than radiology. So if you have a cavernous hemangioma at the orbital apex that you think is surgically unresectable, the imaging may be stable, but if you're following them with visual fields, color vision testing, pupillometry, you may notice subtle changes even before the radiologist is able to see it. So no growth on radiology can't be reassuring entirely. You have to follow the patients very closely clinically as well. So the mesenchymal orbital tumors tend to be a little bit more rare. I'm not going to spend as much time on them, but I think the most important one for you guys to know and to think about in the back of your mind, especially for those doing pediatrics, I heard in the group, is the rhabdomyosarcoma. This is the most common primary orbital malignancy in children. These tend to present with really rapid onset of growth, maybe spontaneous ecchymosis, and these are patients that can progress rapidly over the course of days and certainly weeks. So if you have a young child presenting with spontaneous exophthalmos, rapidly progressive of disfigurement of the eye, these are really rhabdomyosarcomas until proven otherwise. These are patients you really almost should be admitting for expedited inpatient orbital imaging, an initial biopsy as early as possible. And then these tend to be treated with a paradigm of debulking these tumors as much as you safely can, and then giving chemotherapy and radiation. These break down into a few different subtypes, and the survival rate depends on the subtype of the lesion. But again, this is a patient I showed you earlier. We were contrasting the MR versus the CT imaging, and this is really, I think, a matter of days. This was a patient from my fellowship, Gary. I can't remember if you helped manage this patient with me or not, but this was, essentially image 1, and this was several days later, and you can see how, quickly, rapidly progressive this lesion was. This patient ended up passing away from her disease, but these, again, are really diseases you have to sort of jump on these patients right away, get imaging as quickly as possible, rally a team of pediatricians and hematologists and oncologists together to take care of these patients, and to hopefully not just save their vision, but also save their lives. So I think, again, any pediatric rapidly progressive orbital tumor should be considered rhabdomyosarcoma until proven otherwise. These small round blue cell tumors with strap cells, this is just a pathologic image of that rhabdomyosarcoma. Solitary fibrous tumors are sort of this weird umbrella term that we don't need to spend too much time unpacking here, but there's sort of a few tumor types that used to be categorized separately that are now kind of clustered under this umbrella term of solitary fibrous tumors. This was, again, on our differential, those three things: cavernous hemangioma, schwannoma, and solitary fibrous tumor that can present with a well-circumscribed intraconal lesion. These ones you have to be careful because they actually can metastasize. They can go to the lungs, they can go to the livers. And so these are lesions that are typically excised, and then depending on sort of the degree of atypia within the lesion, may be treated with radiation as well. This was a patient who presented to me, really had been sort of neglected for a few years. She had multiple children and didn't want to have surgery while she was pregnant or delivering her kids. But you can see sort of with axial proptosis, the eye sort of being pushed, not just forward, but actually up and out from this kind of inframedial lesion here that's really displacing the medial rectus and the inferior rectus. We approached this with sort of a combined approach. You can see in that location medially, we have our optic nerve here, so we want to think about an approach that's going to be medial to the optic nerve so we don't have to retract or work across the optic nerve. The most minimally invasive way to do these is, in our practice, is sort of a combined approach where we, as orbital surgeons, go from the conjunctiva side, so we'll stay sort of just posterior to the caruncle and travel along the medial wall subperiosteally to access the tumor. We have our ENT colleagues then go endoscopically through the nose, so we're able to work through both sides. There's not a lot of retraction being placed on the nerve. We're not sort of squeezing or pushing on the nerve within the orbit, and we're usually able to sort of safely excise these. So this is just showing that approach, putting some traction sutures, feeling with our scissors for that posterior lacrimal crest to know we're behind the lacrimal system, then using monopolar cautery to open up the periosteum within the orbit, and then travel subperiosteally into that orbital space. And that landmark, again, the posterior lacrimal crest, is really how you know you're outside of the lacrimal system and can sort of safely enter the orbit. So you're actually just feeling for that manually with your scissors. It's not something you can visualize. Once you kind of feel that little ridge, then you can start your dissection into the orbit. This was our patient after surgery, week 1, demonstrating just excision of that lesion. This is another patient with a sort of a mesenchymal type tumor. She had an osteoma. She had Gardner syndrome and had these, you can kind of see them, odontogenic cysts sort of all over her body, but this one was producing, as you can imagine in that location, sort of, it had the superior oblique wrapping around it, was pushing the eye infralaterally and causing her to have double vision. If you look at the corneal light reflex, you can see sort of the difference in alignment there. This one, again, based on the location, we wanted to travel medial to the optic nerve, but this was in the superior quadrant. So in this case, we actually utilized an eyelid crease incision to excise this. And just week 1 is what did well. You can see her kind of realigning those two eyes. So the mesenchymal tumors, again, tend to be a little bit more rare. I kind of left a few tumor types out that are probably not going to be things that you guys kind of see commonly in your clinics, but I think the rhabdomyosarcoma is an important one to think about, and then the solitary fibrous tumors as well. So kind of moving towards our last category of tumors before we move on to some sort of grab bag of things. We have about 25 minutes left. Any other questions for now? It's going too fast, too slow. Doing okay? All right. So lymphoproliferative tumors are really an important category of tumor for several reasons. These are kind of the three main flavors, but we're really focused on sort of lymphoid hyperplasia and lymphomas. They're important for a few reasons. One is because they're very common. They're the most common primary orbital malignancy in adults. So we said in kids, rhabdomyosarcoma is the most common primary orbital malignancy in adults. It's lymphoma. It tends to present with sort of slow, painless growth. In the conjunctiva, I'm sure you guys have all seen these salmon patches that are sort of this pinkish hue. Within the orbit, though, the key sort of differentiating feature is this sort of that behavior they have where they sort of mold and wrap around structures. So in contrast to the epithelial tumors we'll talk about in a second, these tend to just sort of infiltrate. You can kind of think about them like just an army of little blue cells that are just sort of invading and squeezing around and growing wherever they can. So this is sort of an orbital lymphoma on the right side. And you can see it's just nicely molding around the globe. It's not pushing the globe. It's not bothering the globe. It's just kind of filling in space wherever it can, tracking subperiosteally here back into the orbit. And we'll contrast that again with the epithelial tumors of the lacrimal gland in a few minutes. But another key important thing here is that these really need to be biopsied. They're not surgical tumors. The purpose of surgery is just to make the diagnosis so that it can be managed with radiation typically. So it's not a tumor that you necessarily need to remove all of. The goal is just to get a small amount of tissue for diagnosis. And when you're getting that tissue, it's really important to send fresh tissue for flow cytometry. So this can't be sent in formalin-fixed medium. If you want your pathology colleagues to be able to perform flow cytometry. So really important to get good amount of specimen. Our pathologists say for flow cytometry, they want at least a pencil head eraser, so something about a cubic centimeter. So if you can get it, something in that ballpark to allow them to perform the studies that they need to. And it's really important once you make the diagnosis to involve your hematology and oncology colleagues. So these aren't things you need to manage by yourself because there is a risk of systemic involvement. The risk is, sorry, this is getting cut off a little bit. The risk is highest actually for eyelid lymphoma. It's sort of slightly lower for lesions of the lacrimal gland, slightly lower for lesions of just the orbit, and conjunctival lesions, fortunately, which a lot of you will see in your practice, are the lowest risk for systemic involvement. But really, any patient where I was making a diagnosis of lymphoma, no matter the location, I'm going to get my hematology and oncology colleagues involved to do a systemic workup and treatment as necessary. These tend to be B-cell lymphomas. They tend to be mucosa-associated lymphoid tissue or MALT lymphomas, most often B cells, but some are associated with CLL. And again, this is not a surgical disease. This is a disease that's treated with radiation therapy. Rituximab may be appropriate in some cases, but again, that's usually going to be a decision that's made by your oncology colleagues. So again, this is just that image showing that characteristic, we call it putty-like molding, where it's sort of just being shaped around the tissues in the orbit, not pushing, not displacing, just sort of infiltrating between normal structures. And then again, just think of it as like this sort of army of these diffuse, sort of well-differentiated lymphocytes that are sort of migrating through the orbit. Lacrimal gland lesions, I think, do or deserve sort of special consideration because of their frequency. And this is sort of how I think about approaching lacrimal gland lesions, or lacrimal gland enlargement, rather. The most common type of lacrimal gland enlargement is going to be inflammatory etiologies, dacryoadenitis, things like Epstein-Barr virus, other viral pathologies that can cause inflammatory enlargement. That's sort of a separate category for consideration. Infection is probably much less common than inflammation, but does happen. But here we're kind of focusing on these neoplastic lesions. Within those neoplastic lesions, they basically break down half and half into lymphoproliferative lesions, which we sort of just discussed, and then epithelial lesions, which we'll talk more about here. Within the epithelial lesions, again, they break down about half and half into benign lesions, typically the pleomorphic adenoma, or malignant lesions, which are either pleomorphic adenocarcinoma or adenoid cystic carcinoma. We'll sort of treat these separately. I know it was a little confusing when I kind of was first learning about these, but the pleomorphic adenomas can convert to pleomorphic adenocarcinomas, whereas adenoid cystic lesions are a totally separate tumor type. So we kind of talked about lymphoma being the most common primary orbital malignancy in adults, surgery being diagnostic only, and treatment really being radiation whenever it's present. So this is just another example. You can see this is sort of growing just right along that plane in the subperiosteal space. It's really not deforming or displacing the globe, but just molding around all the tissues in the orbit. This was a patient with marginal zone B-cell lymphoma. In this location in the lacrimal gland, the eyelid crease approach tends to be sort of the best way to get right to that tissue. This is radiographic, and obviously this is a cadaver. This giant structure here is the levator palpebrae superioris, which is dividing the orbital portion of the lacrimal gland, which we can see here, from the palpebral portion, which is underneath the levator. Whenever we're doing biopsies, you always want to biopsy the orbital portion so that you don't damage the secretory ductules that are sort of actually allowing tears to pass on the tear film. So you always want to biopsy from the orbital portion. And then this is just an example of a patient who underwent a biopsy for IgG4 related disease of the lacrimal gland. Basically just highlighting that sort of simple anterior lid crease approach. But we're basically incising the skin, dividing the orbicularis oculi here, just going very carefully down into that sort of dead space or potential space between the orbicularis oculi and the septum. Once you sort of get into that space, we're really opening the whole thing widely to expose the orbital septum, getting hemostasis. And now here, this is a high temperature handheld cautery. I'm opening the orbital septum very judiciously, sort of in the area of this lesion, using a lot of blunt dissection. Normally we would see orbital fat once we open the orbital septum, but in this location it's all sort of infiltrated with this IgG4 related disease. And then that's about the size of a biopsy you'd probably need for flow cytometry, sort of that pencil head eraser or so. And just closing up the skin, you don't want to close the deeper layers in an eyelid crease approach. So that's sort of, we talked about the lymphoproliferative lesions, those kind of fall in a variety of categories, lymphoma being the most concerning and the one you really want to get your hematology oncology colleagues involved in. Then within sort of that other benign category of lesions, I'll just go back to show one more time. We looked at lymphoproliferative lesions. Now within the epithelial category, we're going to talk first about sort of the benign mixed tumors, BMTs or pleomorphic adenomas. And these are probably the most common epithelial tumor, and they're an important tumor to know for a few reasons. One, they sort of present with this painless, gradually progressive course over time. And this is something that could be important for tests that you guys have maybe in the next few days, but they're going to present really with slow progressive growth over the period of about a year. They're going to displace and push on the globe in contrast to those lymphoproliferative lesions, and I'll show you in imaging in a second. They tend to be really well circumscribed. They tend to be hard. They sort of have this lumpy, bumpy surface. And the reason that it's super important and the reason that it's on your test is that these are lesions you do not want to do incisional biopsies on. So if we talked about for lymphoma, it's not a surgical disease. The biopsy is diagnostic only to enable treatment with radiation. These are lesions you want to excise in their entirety, because if you just do an incisional biopsy and you open the capsule, over time they can actually convert from a benign mixed tumor to a malignant mixed tumor, or pleomorphic adenoma to a pleomorphic adenocarcinoma. So this is an example, and we can I'll contrast this again directly in a second, but you can see compared to the lymphoma, this is the globe here, and you can see how this lesion is really growing and pushing and displacing or deforming the globe. And this is one that you really want to go in, this being removed with a cryo probe, but really excising the whole thing in total. We're not violating the capsule, we're removing this as one giant piece. So again, for tests that you may take in the next few days, if you see a lesion that's presenting with epithelial qualities, being slow growth, painless nature, pushing on the globe and displacing the globe, you don't want to violate the capsule. You want to remove these lesions in their entirety. And this is again just contrasting that sort of lymphoproliferative molding versus the epithelial displacement or deformation of the globe. So again, incisional biopsy typically treated with radiation, excisional biopsy to remove these lesions in total. And again, the big concern here is conversion. If you incise that capsule, converting the lesion over time from a benign mixed tumor to a malignant mixed tumor. So again, with kind of appropriate planning, this is similar to that eyelid crease incision we did for that IgG4 related disease, but certainly a bit more extensive. But you can kind of see, again, displacing and deforming the globe here, sort of this heterogeneous quality to it. It's not like lymphomas that tend to be a single cell type that are very homogeneous. This is multiple different cell types, very heterogeneous and disforming and displacing the globe, and we remove this in total. Malignant mixed tumors, we won't spend too much time on. They're very similar to the benign mixed tumors, but have undergone malignant transformation, and that's why you never want to violate that capsule with an incisional biopsy. And then just our category here, just to avoid confusion, this is a totally separate subtype of tumor. It has, it's not really related to the malignant mixed tumors, but it's a malignant carcinoma of epithelial, sort of origin that can occur in the lacrimal gland. And the big hallmark distinguishing feature here is pain. So this is a patient who's going to present usually more rapid onset than a benign mixed tumor. And the key feature in the history that you're going to ask for is pain. So this patient's going to either have some type of numbness, some type of kind of strange paresthesias in the area, or just really intense headache, and it's from perineural invasion of these tumors. These can destroy bone. They tend to be more rapidly progressive. They tend to present from over months, whereas those benign mixed tumors tend to present over a period of years. And the treatment is a little bit controversial, but the goal is you want to remove as much as you safely can, and these tend to be treated with radiation afterwards. They don't tend to be very responsive to chemotherapy. This histopathologic pattern has been described as a Swiss cheese pattern. You can kind of see these vacuoles and holes, and just a picture of a mouse eating some cheese. This was a patient who presented with, again, similarly, it's about maybe 3 to 6 months. I can't remember exactly, but the hallmark feature for him was that he came in with just this kind of daily headaches, this sort of dull ache in that supratemporal quadrant, really painful. So even though this sort of looks like it could be, definitely looks epithelial in nature, you could say, gosh, that kind of looks like a pleomorphic adenoma. Pain was the feature that sort of differentiated it from the benign mixed tumors. And this similarly was excised in total, and he was referred for radiation. Yeah. Perineural invasion, so the tumor actually invades the nerves, whereas the benign mixed tumors just tend to sort of grow in place and don't invade structures around them. So the perineural invasion is the reason for the pain, and also your kind of hallmark feature that may be something a little bit more serious. So yeah, again, debulking these as much as you possibly can. They tend to be treated with radiation and chemo. Jeff Rose, who's at Moorfields in London, did a long study looking at over his career of patients who were treated with radical exenteration with a lot of bone removal. And he actually found in his practice patients who had these radical disfiguring surgeries where you essentially were cutting off half of their face actually did worse. I spent some time with him in London and kind of picked his brain on this. And his thought was basically that these tumors were then seeding the bone. So his goal was to sort of leave as much bone intact as possible, remove as much of the tumor as you can from the orbit, and then treat these with radiation afterwards. There are some people, including David C. at Bascom Palmer in Miami, that are treating these with intra-arterial chemotherapy, where the neurointerventional colleagues will actually thread a cannula up into the lacrimal gland artery and inject chemotherapy first before surgical debulking. The results are sort of mixed, but I think from a framework perspective, try to remove as much of the tumor as you safely can. Don't bother these gigantic disfiguring surgeries, and they're always going to need radiation afterwards. So that's kind of a big run through of our big tumors. And then I'll kind of talk a little bit about some sort of secondary and metastatic tumors, which are going to kind of come into the orbit from other places, but that was kind of a run through of most of the common primary orbital tumors you'll see within the eye socket. Any questions there before kind of moving on to this last section? All right, so tumors, we looked at our kind of initial list. Vascular tumors were the most common. Sort of after that was these secondary orbital tumors. So these are not tumors originating within the lacrimal gland, but coming from other places. And this can really be anything from the sinuses, from the skin, from the brain, metastases from different parts of the body. Probably the most common secondary invading tumor are squamous cell carcinomas like this one. Similar to the adenoid cystic carcinoma, they can spread along the nerve. So they can start in the skin here in this location, maybe track along the infraorbital nerve back into the eye socket. Rather than pain, these patients often present with what's called fomication, which is sort of the sensation that like bugs are crawling on your skin, but again, it's just sort of like paresthesia from the actual perineural invasion itself. So you always have to have a high index of suspicion in any patient with sort of a periocular basal cell, squamous cell, sebaceous cell, Merkel cell, anything that sort of looks like it could be invading the orbit. Radiographic imaging is helpful, having a really high index of suspicion or kind of being worried about these patients and following them closely over time to make sure even if you're a dermatology colleague or you excise the basal cell, that you haven't missed some orbital extension or secondary extension. This is another patient I showed you a photograph earlier presenting with really dramatic displacement of the eye. And this was, not really a tumor at all, but a frontal sinus mucocele. So he'd had a prior trauma. Someone had sort of put a plate across near the frontal sinus outflow, creating this mucocele where the mucus that was produced within the frontal sinus could not drain. Over time, this sort of produced slow displacement and remodeling and growth of the bone to the point that it was hugely displacing and disfiguring his eye. This was just an intraoperative photo showing from the endoscopic sinus surgery, draining all that pus. The paradigm for how to treat these has changed a lot over the years, and currently we're sort of at a place where we say that these mucoceles really only needed to be treated with sinus surgery. And I'll show you in a second that this is him sort of slowly over time after just sinus surgery, and he was actually lost to follow-up, so we have not seen him back. But this was the course of just over 4 months, and this bone is so thin, and from the pressure of the orbit does tend to remodel with time, so you don't always have to go in and do big reconstructive surgeries. The first step, and maybe the only step, is just functional sinus surgery, usually with your ENT colleagues. We saw in that list in the very beginning, metastatic lesions are very common. Probably the most important one to know about, which we already talked about, is breast cancer. This can often present with that cirrhotic sort of contractile changes and actually present with enophthalmos rather than exophthalmos. Other common types, melanoma certainly can go anywhere, as you know. Lung is very common. Renal cell can involve the orbit and can actually be very bloody and challenging to treat, and prostate cancer in men. So certainly, you can see these are 2 different series. They're probably the biggest ones available. This is a Wills one that we referenced earlier, these 1,200 consecutive patients. And this is from MD Anderson, Vitas Molly's group. And you can see there's some differentiation, probably regionally, demographics of the patients in their practice. They're not exactly the same, but you can see some of these, breast being certainly the most common in both groups, and sort of common patterns of how these present. This is an example of a female patient presenting with exactly what we've described, sort of that enophthalmic appearance. She's got a deep superior sulcus, ptosis, and sort of when you measure on her telex ophthalmometry, you can see on the scan the left eye is actually further in from this sort of cirrhotic breast cancer changes. This is a gentleman presenting with, he was a smoker, smoked for many, many years, presenting with metastatic lung cancer, sort of just this poorly differentiated infiltrative lesion that ultimately actually required exenteration and removal of the eye. If you just kind of random lesions that you may see commonly in kids, I know I keep saying, but I know there was a few pediatric people in the group. This was just a very well circumscribed lesion, presenting kind of painlessly, growing slowly in a young kid. You can see on imaging, this is a T2 image highlighted by the bright vitreous. So this is showing fluidic sequences. Things that are bright on T2 are tend to be water-based. So you can see just a really well circumscribed fluid-filled lesion that ended up being a lacrimal gland cyst. This was approached through that inside of the eyelid approach. Because he was a young kid, we didn't want to disfigure him too much. We didn't do that sort of disconnecting step with the eyelid that we showed in the earlier case. Just went through the inside of the eyelid and excised this thing in total, but just a benign lacrimal cyst. I think the reassuring feature here again is just how fluidic and homogeneous this is, in addition to the location near the lacrimal sac. And this is kind of the last one I think we'll talk about. These are probably perhaps the most common type of pediatric orbital tumor in my practice. You could almost miss it. This is how she showed up in my clinic after a carnival at school or something that day. But this really well circumscribed lesion in the supratemporal quadrant, right at that suture line between the frontal bone and the zygomatic bone. And I see a few of you nodding your head. I'm sure you guys have seen these in your practice. Really well mobile, kind of you could move it around, rubbery cystic lesion that's consistent with a dermoid cyst. Oftentimes in kids, just to save them the radiation or the anesthesia necessary to get an MRI, I'll excise these primarily just because they're so common, they're so predictable, they happen so often in this location. We'll excise them without any imaging. Certainly if there's anything intraoperatively that we find that's concerning, we can get imaging afterwards. But I try to avoid radiation in kids if possible. And these can nicely be removed through eyelid crease incisions. I see my colleagues in dermatology and ENT making big incisions on the side of the face, but these hide really nicely in that natural eyelid crease. And with just a bit of retraction and dissection, you can usually remove these in total without anything disfiguring. Yeah.
Do you, in your daily basis, do the transillumination?
You can, yeah. Sometimes it's helpful in sort of determining more. I find for hydrocystomas and things that are a little bit more superficial in the skin. For deeper lesions, they may not transilluminate, but it's a great test to perform to see if it's sort of fluidic filled, well circumscribed lesion. I think that's it. These tend again to kind of present at the front of zygomatic. They can present at the frontoethmoidal suture line. So we talked in the beginning about things below the mediocanthal tendon being lacrimal sac, things being above the mediocanthal tendon being a little bit more concerning, but these lesions can occur kind of in that location right at that frontoethmoidal suture line and tend obviously to be benign lesions. They're going to feel a little bit different than things that are more concerning like malignancies or encephaloceles, just rubbery, kind of mobile. You can usually kind of move them around pretty easily. And the big key when you're removing these, just try to keep it intact, so really meticulous, gentle dissection. If they pop, it's hard to kind of get the full extent of it, and they may reform or recur with time. And this just demonstrates sort of that cystic quality to it. This is another one you guys may see commonly in your practice. This, people presenting with this orbital tumor. This is, kind of has a lot of reassuring features. It's right on the globe, sort of this yellowish, kind of fatty-looking appearance. And this is really just focal weakening of the septum and herniation of the orbital fat through it. So it's not really a tumor at all, just benign orbital fat prolapse. These can be either observed, certainly, or conservatively debulked. The way that I'll do it is sort of make my incision. You want to, basically they tend to occur in this outer quadrant, so you want to stay away from the lacrimal gland and the ductules that sort of, pass all the tears through. If you go too high and too lateral, you can violate those, and scarring can actually block the tear outflow. So I tend to sort of stay perilimbal, just make the smallest possible opening, let the fat herniate, judicious cautery in that location. Don't go too far back into the orbit. You can kind of, obviously create strabismus, scarring, all kinds of things. So the smallest possible opening, let the fat herniate and prolapse, and just really conservatively debulk. It's always easier to come back on another day and take more fat than it is to treat refractory dry eye or strabismus if you get, a little bit too surgically aggressive. And then this is just a photo sort of differentiating what we saw in that last photo, the orbital fat prolapse versus a lipodermoid. So you can see the orbital fat prolapse really has that kind of yellowish, characteristic fatty appearance, whereas this lipodermoid tends to be a little bit kind of pinker. It's much more solid. It doesn't have that squishy fat appearance. You can't really displace it. So they're similar in their sort of initial presentation, but have a few characteristic features that are differentiating. These similarly, they're just benign tumors. This young girl had it since she was born, but I think she was 16 or something at the time that we removed it, was entering high school, didn't like kind of the disfigurement in the presentation there. Similar to the orbital fat prolapse, I think the key here is just being as conservative as possible. You really don't want to give her a new problem for something that's benign. So we tend to just sort of, be very conservative in how much we open them, how much we debulk them, really try to stay out of the orbit. And again, they may have kind of these deeper extensions into the levator and the extraocular muscles, so you want to kind of avoid manipulating those if ever possible. And that was just a picture of it after being excised, and then just again, kind of that cystic sort of fatty, enhancement appearance on imaging. So that's all I have for you. Again, hopefully not too much of a laundry list, but ran through some of the most common tumor types, a few thoughts, and sort of how to work these up and approach them, when to get your colleagues in neurointerventional radiology, hematology, oncology involved, ENT involved. Never feel like you're alone in managing these lesions. They're certainly rare, and if you encounter one that you haven't seen before or don't feel comfortable managing, orbital tumors are so rare that it's really important to rely on your colleagues with a lot of experience. So if you have someone in your region who's kind of an orbital specialist, they're always happy to probably have cases bounced off them or referred to them, but don't always try to manage these on your own if you're not comfortable with it.